welcome everyone. As Harry mentioned, we're going to be talking about the most cited deficiency within the conditions of participation for hospitals, and that has to be restraint and seclusion. It's actually culminated into what they call the patient rights section. Again, that's the most cited area in the entire conditions of participations for hospitals, and that's both acute and critical access. What are we talking about today? We're talking about the many restraint requirements that CMS has for hospitals. It will talk about education requirements that have to be in place for your staff. We're going to talk about an order that's required on restraints, and that electronic reporting is now required for deaths resulting or surrounding the use of restraints and or seclusion. And this is the reason we're here, so we don't get one of these. Statement of deficiencies, and of course, definitely not the one in the lower right corner, which is your notice of involuntary termination from Medicare and Medicaid. So why are we doing this? Because of course, we never want to see these headlines. You know, when you have a patient, 16-year-old, who dies during restraint, and she already had issues, and she died under our care. We've got a hospital that was fined because of a man who passed away when he was in restraints. And he was restrained face down by several employees. In fact, in my state, we've even banned that one fatal restraint use. And it happened because of a state mental health hospital patient that we had here who was restrained face down. And he wasn't a nice person, I will grant you that. But unfortunately, the way he was restrained, he was face down, arms at his side, and he suffocated, essentially. CMS will investigate the restraint deaths. In 2017, it talked about a hospital in South Carolina, and they lost the contract because they refused to straighten up their deficiencies. It was a 48-year-old patient who was strapped to a gurney. Same thing, died of traumatic asphyxiation. The coroner went so far as to list his death as a homicide. That is the reference that I had made to that hospital. So now we need to start rethinking restraints. Back in the old days when I was doing bedside nursing, I must admit we used restraints somewhat without concern of what we're facing right now. And CMS wasn't citing hospitals at that time regarding this issue. Now, what this study happened to find was 27,000 patients are restrained each and every year. About 5% of the hospitals had to do this, so that's 50 per 1,000 patient days. They're increased, and it also increases the risk for delirium, which makes sense. If a patient can't get up and sit up and get oriented to where they are, it's going to increase their delirium. Restraints increase the rates of, course, pressure ulcer, respiratory complications such as strangulation because they're up around their neck, or aspiration. And Health and Human Services, when they did their study in 2006, found that 40% of the hospitals, unfortunately, don't report deaths as a result of restraints. So now it's time to start rethinking them. How we use them, how often we're using them, for what patients we're using them, how long we keep them on. Now, there was a study in August of 2016 that did found they're used less often when RNs are on duty. And in fact, they found that it was steadily declining the use of restraints. They found it can lead to agitation, confusion, other psychological effects such as a feeling of fear and PTSD. Hospitals have compensated, unfortunately, the shortage of those RNs with other staff, but it didn't help reduce the use of restraints. In fact, it increased the use of restraints. And also the quality of care suffers. And what they're finding is that by the more nurses, the more RNs in particular who can do this assessment of patients who are suffering for this and use other interventions, that may decrease the need. It looked at data, almost 1 million patients at over almost 900 hospitals that were on med-surg unit. 1.6 of those patients were restrained. Over half of them were restrained simply to prevent falling. During this 4-year study and what they implemented, the use of restraints dropped 50%, implementing some of the suggestions they had in. And one of those in particular was the more RNs you have, the lower use of restraints you're going to need. The odds of using a restraint were 11% and 18% higher if you had fewer RNs on staff. And the odds of using restraint to prevent a fall were almost 17% higher. Again, the RNs were better trained to find alternatives, not only to restraint, but seclusion. And physical restraint is a very broad term. It includes everything from mittens to vest, from side rails to cherry chairs. And what this study noted, it's not the number of staff they have present, it's rather adequate number of RNs. I'm going to take a moment to talk about and just do a quick introduction on the restraints and the conditions of participation surrounding them. Everything, by the way, starts in the Conditions of Participation Manual. If any hospital participates or receives federal support and money through Medicaid and or Medicare, they must comply with all of those conditions of participation. And that doesn't matter if it's a Medicare or Medicaid patient, it's every single patient. The sections are split up into tag numbers. Everything starts in the Federal Register. That's where the laws start. From there, CMS will develop and publish their interpretive guidelines, which is, hey, this is what we think it means. This is what we need to see in place or what has to happen. Some, and most of them actually have survey procedures, and that's what the surveyors will do once they're physically on site. They'll talk to people, including patients. They'll look at documents. They want to see policy and procedures also. So keep an eye on the website to see if there's any changes that come through. The most current manual right now has been as February of 2020. Now, there were to be many changes and updates to that manual, such as interpretive guidelines added. But of course, with COVID, the pandemic, things came to a screeching halt, and we don't have them. Initially, well, hopefully by the end of 2020 we'll have them. Well, we're now into 2021, and we still don't have them. I just want to show you this slide, number 19, that will give you the overall index to the appendixes for the manual. Psychiatric hospitals used to have their own. They are now put into Appendix A. So they also have to follow a lot of the requirements aside from what's already in theirs too. W, Appendix W is for critical access hospitals. I am going to make mention of both of these hospitals as we go through. This is the appendix for the A manual, and it includes everything in there and a lot, again, on what we're going to cover. And this is the appendix for Appendix W. There are some differences. Just be aware of that. As far as the memos, and you'll hear this throughout, CMS published this memo and that memo. The memo is what CMS puts out for their surveyors to obtain, and it's available to us, the public. So we know what they're thinking, looking, doing, and starting, what their requirements are. Right now, most of it has been around COVID. Some of the more recent memos talked about reinstituting and starting up surveys again, loosening restrictions on long-term care visitation, even hospital visitation. So they're starting to come back now to full swing. And on each of these links, I include the internet access for you, so you can go in and get it. I will tell you, don't copy paste. Unfortunately, you will have to type it out because sometimes they get fussy and say the site doesn't exist. It's there. It's just sometimes maybe you need to take off some of the last few letters, but they are there on what they're expecting. Of course, to keep up with all changes, it's beneficial to sign up to get the Federal Register. You just pop in your email and hit submit, and pretty much daily, you will be getting information from the Federal Register because they cover everything from the CDC, National Institutes of Health, Health and Human Services, everything. Let's talk about complaint data. I started off by saying that this was the most cited area. So when I say citations, complaints, that's the same thing. You can access that data. So when surveyors come back, they upload all of this information into this database. And they call it the complaint data, but it's the citation data. That includes not only the tag numbers, but the name and address of the hospital and the date the survey was done. It may also include a brief description of what the deficiency was. Sometimes they do have to wipe that out due to confidentiality. One thing it does not include is the plan of action.